I want to step back and take the prognostic score now by group. So if we look at the intermediate to poor risk group as a collective, and I know those aren't the same, but we recognize on this spectrum the intermediate to poor risk are sort of that half of the spectrum. Rich, now we have some studies that have specifically focused on those populations and have given us some new data and perspectives on this. How are you choosing for your intermediate and poor risk patients which therapy to start with?
Yeah, this is, I think, one of the most critical questions that I have in the clinic right now. It was when you presented with an intermediate poor. Now we have at least one phase 3 study with Ipi/Nivo showing superiority in both overall response and overall survival, and pretty close to PFS. I guess it was statistically not there. Then you have the phase 2 Cabo-Sun, where you have Cabo beating out sunitinib, and so now but neither of them have been compared head to head. So how do you go with an immune versus a TKI? Well, obviously the easy things are if they have immune problems, okay, well that makes it easy. But what if they don't? Well, some of the things that I think about that I don't necessarily know for a fact are true, but at least from experience, is perhaps maybe the bone predominant patients might be better fit for a TKI rather than immunotherapy. I think PD-L1 status might be able to help you, especially the patients who are PD-L1 positive seem to have even more improved outcomes over the TKIs. There is some question about maybe even in Cabo, and this is not something we do routinely, but maybe a biomarker for them, maybe MET expression could perhaps, that's not something I have used, but maybe it's a hypothesis generating way of trying to select patients that might go that way. But I don't really have a great answer for the question other than the obvious ones like history of autoimmune disorders.
Tony, what about you? How are you choosing? Because there are tools available, then there are tools that are not available. There are clinical trials we can ask, but at the end of the day, you got to do clinic next week, and you see a newly diagnosed intermediate risk patient. What are you gonna start them on?
Well, bearing some clinical trial was always my first choice. I think that with the overall survival benefit from CheckMate 214, you have to see what are the reasons of not giving nivolumab, ipilimumab. You'll be surprised. We still, despite the great electronic medical record system, we still have to take good history. You'll be surprised how many patients have autoimmune disease, whether in remission or not, and are on methotrexate, etc. So that's one. Second, predominant bone disease, there is data evolving with cabozantinib. Third, something we don't talk on trial is that, as you know, 1/3 of our patients are not eligible for trial. We looked at that from the IMDC database, and some of those patients, what can you do if they have organ dysfunction? And fourth, and most important, is when someone has a very, very aggressive disease and you can't get nivolumab, ipilimumab, immediately, the rate of PD as best response with cabozantinib, both on Cabo-Sun and on Meteor, the second line, is really low, while with immunotherapy it could be high. Perhaps this is something that can slow down the disease. Not different from chemo versus checkpoint in bladder cancer, for example. So that's another reason to consider it. And let's not forget, Walt was saying that we do have today, I would think, for the community oncologist, more experience with VEGF TKI and management rather than checkpoint inhibitor or double checkpoint inhibitor. So these all factor. It's not an easy thing, and it's going to get, I would think, more difficult when the combination VEGF-IO come into play.
Absolutely. We're going to get to that in a minute.
And we'll get to that. And I think that, I think that that's fascinating, Tony. And one thing I may want to come back to a little bit with, from what Richard said in regards to these trials, bringing up more questions sometimes than they answer. I have been impressed not only with this intermediate poor risk data, level 3 data, but corroboration in the clinic where sometimes some of our worst patients actually do pretty well with this immunotherapy as opposed to the good risk, which sort of putter along. And so my clinical experience mirrors what the level 1 data shows us. And one of my questions is, why? What is the biology behind that? I mean, poor risk basically says patient doesn't look so good, isn't doing so well, and here's some labs, but that doesn't tell me about why this is happening. I think it raises some very interesting hypotheses, which will hopefully get us to a more refined selection of our therapies.